You have not missed a dose in years. You take your blood pressure medication, your cholesterol medication, your bone medication, something for your stomach that was added 2 or 3 years ago, something else that came after a blood test, the specific reason for which you no longer quite remember, but that has been refilled without question every 90 days since. You go to your appointments, you get your blood drawn, you fill the prescriptions. You do, in other words, exactly what you were told. And yet every year, quietly, measurably, undeniably, you feel a little worse than you did the year before. Not dramatically worse, not in a way that produces an emergency or a new crisis, just less. Less energy than last winter, less clarity than the year before that, less physical ease, less resilience, a slower recovery from anything that asks something of you. Less of the person you were 6 years ago, before this many prescriptions, before this many appointments, before health became the primary occupation of your days. You have followed every instruction, you have done everything right, and you have gotten worse. Nobody has explained why. I want to explain why. In this video, I am going to show you the specific mechanism by which perfect compliance with a static medication list produces annual decline in an aging body. Not despite the medications working, but partly because of how they work, in a body that is not the same body that first received them. This is not a story about wrong prescriptions or careless prescribers. It is a story about a system that calibrates once and recalibrates almost never, and what that costs year by year in people who have done nothing wrong. At around the 8-minute mark, I am going to tell you about a phenomenon that affects a significant proportion of adults over 70 on 5 or more medications, one that has been documented in the research literature for years, that geriatricians understand well, and that almost no primary care physician has discussed with you. It has to do with the number your doctor watches most carefully, and the finding may reverse something you have been taught to believe about what good medical management looks like. I have spent more than 3 decades in geriatric medicine. The pattern this title describes, doing everything right and feeling worse every year, is one of the most consistent things I hear in clinical practice. And it is almost never named for what it is: a predictable, measurable, and in many cases addressable consequence of a medical system that manages medications for the condition they treat, but rarely for the body receiving them. Let me give you a way to hold this before I give you the science. Every medication dose is a calibration. It was set, adjusted, titrated, finally landed on, based on how a body of a certain age, with a certain weight, with a certain kidney and liver function, processes and responds to that drug. That calibration was made at a specific point in time. It was made once. A calibration made once is accurate for the body that existed when it was made. But bodies change. Kidney function declines by roughly 1% per year after the age of 40, consistently, measurably, in almost every person regardless of disease. Liver enzyme activity reduces, body composition shifts, with lean mass declining and fat tissue increasing, changing how medications distribute and accumulate. Every one of these changes alters how a medication behaves in the body. The medication does not know this. The prescription bottle does not account for it. The refill continues without adjustment. And the calibration that was right at 66 becomes slightly off at 69, and more meaningfully off at 72, not because anything in the prescription changed, but because the body it was calibrated for no longer exists in exactly the same form. This is not negligence. It is a structural gap. Medicine is extremely good at initiating treatment. It is considerably less systematic about returning to established treatments and asking, does this dose, written for the person I was treating then, still make sense for the person sitting in front of me now? For most people over 65 on multiple medications, the answer has not been asked. And the consequence of not asking it accumulates, year by year, in a direction that feels indistinguishable from aging. Let me be specific about the mechanism, because the details are what make this actionable. When your kidneys process a medication less efficiently than they did 5 years ago, which for most adults they do, the drug stays in your system slightly longer before being cleared. Not dramatically longer. Not enough to produce a single alarming result on a blood test, but slightly longer, at slightly higher concentrations, with slightly more time to produce the effects, intended and unintended, that the drug was designed to create. This happens every year, incrementally. The body's processing capacity declines, The drug's clearance slows. The effective concentration in your blood rises slightly above what the calibration intended, 1% at a time. The side effect profile that was acceptable at the original dose becomes less acceptable at the effective dose the body is now actually experiencing, even though the number on the prescription label has not moved. Multiply this across 5 medications, across 6 years, and you have a pharmacological burden that has been escalating annually. Not because anyone increased a dose, not because anyone prescribed carelessly, but because a system that calibrates once never returned to recalibrate. Now add the second layer, the polypharmacy ceiling. Research on adverse drug events in older adults has identified a threshold beyond which the probability of a meaningful adverse interaction is no longer a risk but a near certainty. 5 or more medications. The risk of a clinically significant adverse event rises steeply. 7 or more. Researchers have found that the majority of patients in this range experience at least one adverse interaction. 10 or more. Documented harms begin to significantly outpace documented benefits in population-level analysis. Each year, for many older adults on complex medication regimens, the list grows by 1. The symptom that appeared last autumn prompted a new prescription in December. The side effect of that prescription will appear in the spring and be treated with another by summer. The ceiling approaches not in a single dramatic step, but in the same quiet annual increments as the pharmacokinetics change. You feel worse each year because the equation is getting harder each year. Not louder, not more visible, just harder. I want to tell you about a patient I worked with. No name, because this particular pattern is common enough that naming it risks making it sound exceptional when it is not. She had been on 5 medications for 6 years. Every appointment, her numbers looked controlled. Blood pressure in range. Cholesterol at target. Blood sugar managed. Her primary care physician, reviewing her chart before each visit, saw a well-managed patient. Her chart supported that conclusion. And yet, at each visit, she described feeling a little worse than the time before. Slower, more fatigued, less clear. The response, each time, was consistent with what was visible in the chart. Your numbers are good. This is likely just age. What no one had done in 6 years was compare her current kidney function to her kidney function when the medications were first prescribed. When we obtained her old labs and placed them next to current ones, the creatinine, a marker of kidney function, told a different story than her chart narrative. Her kidney function had declined by over 30% from the baseline at which her doses had been calibrated. She had been effectively receiving doses that were 30% higher than intended for 6 years. Not because anyone prescribed incorrectly, but because nobody had returned to the calibration. Working carefully with her prescribers, her doses were reviewed against her current kidney function. 3 of the 5 medications were reduced. 1 was replaced with a formulation that required less renal clearance. The changes were modest. The result was not. Within 5 months, she described her energy as the best it had been in years. Her clarity had returned to something she recognized. The fatigue that had been attributed to aging showed its actual origin. It had not been aging. It had been a calibration, made once, never revisited, growing increasingly wrong each year while the chart reported everything was fine. Now, the 8-minute mark, the number your doctor watches most carefully. Blood pressure. The management of blood pressure in older adults has undergone significant reassessment in recent years. And the finding at the center of that reassessment is one that most patients being treated for hypertension have never heard. In younger and middle-aged adults, lower blood pressure is generally better. The relationship between lower pressure and better outcomes is fairly consistent across that population. Guidelines were built on this relationship. Treatment targets were set, and those targets have been applied across the board to adults of all ages. But in adults over 70, the relationship is not linear. It curves. Research, including large observational studies and the analysis of major clinical trials, has identified what is called a J-curve relationship between blood pressure and outcomes in older adults. Below a certain threshold, outcomes begin to worsen. Not improve. Worsen. Specifically, in older adults with existing cardiovascular disease or reduced vascular compliance, which describes a significant proportion of adults over 70, systolic blood pressure that is aggressively treated below certain thresholds has been associated with increased rates of cognitive decline, increased fall risk, increased cardiovascular events in some subgroups, and higher all-cause mortality. The mechanism is not complicated. Older blood vessels are less elastic. An older brain depends more heavily on adequate perfusion pressure to receive sufficient blood flow. When blood pressure is pushed below what that brain requires, the result is not better outcomes. It is hypoperfusion, chronic mild underpressure to critical organs, that presents as exactly the symptom cluster you may be experiencing. Fatigue, cognitive fog, dizziness on standing, reduced exercise tolerance, the general feeling of a body running below its own requirements. Your blood pressure numbers look excellent, and that, in some cases, is the problem. I want to be precise here. I am not telling you to stop managing your blood pressure. Uncontrolled hypertension is dangerous. The research on treating blood pressure in older adults is complex, and the appropriate target for you individually requires a conversation with your physician that accounts for your specific vascular profile, cognitive status, and overall condition. What I am telling you is that a blood pressure that looks like a success in a chart can, in some older bodies, be producing the symptoms you have been attributing to age. And that conversation about whether the target being pursued is the right target for your individual body has likely not happened. Here is what I want you to hold before I give you the protocol. The decline you have been experiencing is not inevitable. It is, in a meaningful number of cases, mathematical. A calibration made once in a body that has since changed. A dose that was appropriate for the kidney function of 6 years ago applied unchanged to the kidney function of today. A treatment target designed for a population average, pursued without asking whether it suits the individual in the chair. These are not failures of medicine's intentions. They are failures of medicine's recalibration. And recalibration is something you can ask for. 3 things. All of them are requests, not demands. All of them are medically legitimate. All of them can change what happens next. The first is the baseline comparison request. At your next appointment, ask your physician to pull your creatinine level from the time your current medications were last comprehensively reviewed, ideally from 5 or more years ago, and compare it to today's level. Most electronic health record systems make this straightforward. The comparison tells you how much your kidney's processing capacity has changed since the calibration was made. If the decline is significant, and in many older adults it is, the conversation about dose appropriateness follows naturally. The second is the dose recalibration conversation. Ask specifically, given how my kidney function, body weight, and body composition have changed since these medications were first prescribed, are the current doses still the right calibrations for my body today? Write that question down before the appointment. Say it out loud. It will be the first time, in many cases, that this specific question has been introduced into the room, and it changes what happens in the room. The third is the decline documentation. For the next 2 weeks, keep a brief daily note, a single line each morning, rating your energy, your mental clarity, and your physical ease on a scale of 1 to 10. Do this consistently for 14 days. At the end of 2 weeks, you have an objective, dated record of a trajectory, not a feeling, not a subjective impression, a documented pattern. Bring it to your next appointment and say, "This is what I have been experiencing, and I would like to understand whether it is connected to my medications." A chart with numbers is harder to dismiss than a conversation about how you feel. Go back to where we began. You have not missed a dose in years. You have done exactly what you were told. You have sat in the waiting rooms and answered the questions and filled the prescriptions and returned every appointment with the compliance that was asked of you. And you have felt worse every year. The answer to why is not that you are failing. The answer is that the system calibrated you once and has not returned to ask whether the calibration still fits. That is a question you now know to ask. And asking it, specifically by name, with the language in this video, is how the recalibration begins. If someone you know has been on the same medications for 3 or more years, feeling gradually worse while being told their numbers look fine, please share this video with them. The gap between good numbers and good health is one of the most important gaps in modern medicine. Naming it is the first step toward closing it. Before next week, I want you to do one thing. Find a blood test result from 5 or more years ago, from your medical records, from a patient portal, from a paper file wherever you keep them. Find the line that says creatinine. Write down that number. Then find your most recent blood test and find the creatinine on that one. Write both numbers side by side. The distance between those two numbers is a measure of how much your body's drug processing capacity has changed since your current medications were calibrated. Next week, I'm going to show you how to interpret that number, specifically how to calculate the kidney function it represents, and what a changing creatinine means for every medication you take. Bring both numbers. What I'll show you next week is one of the most immediately useful conversations you can have with your prescriber, and it starts with what you find on those two pieces of paper. One important note before you go. Everything in this video is for educational purposes only, and is not a substitute for the guidance of your personal physician. Please do not adjust any medication, including blood pressure medication, without speaking with your prescriber first. The J-curve relationship I described is real and documented, but whether it applies to your individual situation requires clinical judgment by someone who knows your full health history. The goal of this video is not to make you distrust your treatment. It is to give you the specific questions that make your treatment better.